why we're maybe not thinking about oliguria correctly in critically ill patients. Now, it's been associated with patient outcome for more than 2,000 years, and it remains an important visible sign of underlying potential renal dysfunction. But modern definitions of oliguria require observation over an extended and contiguous period of time, 6, 12, 24 hours. And diuretics, fluid bolus therapy and altered hemodynamic targets using vasopressors can transiently improve urine output, delay recognition, diagnosis and subsequent intervention in patients who are clinically deteriorating. Recent work has demonstrated that low total urine output over the first 24 hours of ICU admission appears to be of particular significance in relation to intensive care mortality. And other large database work has demonstrated that isolated oliguria in the absence of changes in serum creatinine is both frequent in critically ill patients and presents a long-term hazard as it alters patients' mortality for up to a year after ICU discharge. To our knowledge, no study has looked at the significance of the accumulating number of hours of oliguria as a risk factor for subsequent patient-centred outcomes. And to our knowledge, the modern use of absolute values of oliguria, which are not weight-based, remains relatively unexplored. Such early oliguria in the first 24 hours of ICU admission may represent accumulating renal distress and might contribute to a multi-hit model of organ dysfunction. Similar relationships have been seen recently with recurrent episodes of hypotension, recurrent episodes of hypoglycemia and recurrent episodes of acute hypoxemia. Early in the ICU admission, such episodes are likely to be reflective of the underlying admitting pathophysiology and may be more likely to be associated with the ultimate outcome of that diagnosis. We therefore designed and carried out a retrospective observational study to explore the epidemiology of early oliguria in the intensive care unit, with the aim of understanding if the accumulating burden of such oliguria is associated with patient-centred outcomes. We obtained ethics approval from both the Austin Hospital and Monash University. The Austin Hospital is a tertiary referral hospital in Melbourne, which has quaternary services for liver transplant and spinal medicine, and has the full suite of surgical specialties. Patients came from the free cohort, which is the Fluid Resuscitation Epidemiological Database. This contains data on 2,698 first admissions to the intensive care unit between 2011 and 2012 and represents more than 226,000 patient hours of data, which was formed from a combination of electronic medical records, electronic fluid balance charts, the local ANZICS core APD data set, local Kestrel biochemistry and hematology data, and the point of care blood gas analysis data for our unit. From this cohort, we excluded 787 patients, some because they were dialysis dependent on admission and had no urine output, some because they were either discharged or died within 24 hours of admission, and excluding them reduced the mortality bias. No baseline creatinine within 6 hours meant that we were unable to calculate we were unable to reasonably calculate patients' risk of AKI. This left us with 1,911 patients and 196,000 hours of patient data. We defined oliguria as an absolute urine output less than 30 mL per hour, and we defined early oliguria as a binary variable, which was positive once patients had accumulated 4 or more hours of non-contiguous oliguria in the first 24 hours of their ICU stay. We defined the burden of early oliguria as a continuous variable, representing the number of hours which they had been oliguric for over the first 24 hours of their stay. AKI was staged using the KDIGO criteria. Given the number of comparisons and the nature of the study, for initial comparative statistics, we used a p-value of less than 0.001 for statistical significance. The association between burden of oliguria and outcomes were examined using logistic regression, which we then adjusted for illness severity using the ANZROD score. At this point, a p-value of 0.01 was considered statistically significant when we were examining the odds ratio. The ANZROD score is a score specific to the Australian and New Zealand population that's based on the most recent release of the Apache 3 scoring system, but is excellent discrimination and good calibration for the prediction of mortality in the critically ill patients that form our patient population. Oliguric patients are those patients who accumulate 4 or more hours of early oliguria where they had a trend towards being older. They were more likely to have a balanced sex distribution, and they were sicker with higher Apache 3 scores. Early oliguria was common, with more than 60% of our cohort becoming oliguric, and oliguric patients experienced a median of 8 hours of oliguria in the first 24 hours of their ICU stay. Figure 2 demonstrates a clear difference in the hourly urine output between the groups over the first 24 hours of ICU admission. And this is confirmed in Figure 3 by introducing an interaction variable between oliguria status and time into a repeated measure analysis of variance model, where the overall differences in cumulative fluid output on the left and cumulative urine output on the right over time were demonstrated to be significantly different between the oliguric and non-oliguric groups. Significant differences were also demonstrated in the process of care, with early oliguric patients being less likely to be ventilated at admission, but requiring ventilation for longer. There was a trend towards longer ICU length of stay, but ICU and hospital mortality were significantly greater in the early oliguric group. Despite no difference in baseline creatinine, early oliguric patients were significantly more likely to require renal replacement therapy and significantly less likely to be serum creatinine AKI free at all time points. I think I might have just broken the computer. No, we're good. Figure 4 shows a Kaplan-Meier curve of the probability of remaining oliguria free over the first 24 hours of ICU admission. And each of the lines represents a different hourly definition of oliguria to explore what happens when we change our definition of the intensity of oliguria. And it's clear that the more lenient your definition of oliguria, the more rapidly you can diagnose oliguria. In intensity-based sensitivity analysis, where we define the oliguric group by these definitions, the characteristics of the patients change as well. I'm not sure what's happening with... Oh, there we go. They have different demographic features, different patterns of interventions, different renal outcomes, and there's a different and non-linear rate of intensive care and hospital mortality. On logistic regression analysis, once we account for illness severity and the risk of death using the ANZROD score, the cumulative burden of early oliguria is significantly associated with the development of subsequent stage 2 KDIGO AKI and intensive care mortality and hospital mortality, irrespective of the definition of intensity that we use for oliguria. These relationships aren't consistent in our weight-adjusted cohort. This primarily represents post-operative patients who may not be the same as our emergency admissions. Our key findings were that early oliguria is common and that patients with early oliguria have different characteristics to those without, and that early oliguria is independently associated with a greater risk of AKI and death in ICU or in hospital. For the first time, we've demonstrated that cumulative burden of early oliguria, not just consecutive periods of oliguria, is independently associated with adverse outcome, and it may more accurately represent cumulative renal stress in the peri-admission period. And it may be also a more robust measure to interventions such as diuretic and fluid administration. Absolute values of oliguria may be more useful than weight-derived definitions in population-level analyses of undifferentiated critically ill patients. It has all of the weaknesses of a retrospective observational study, but it's granular, and it's in a large cohort, and it's in the sorts of patients that we look after. And I think, I'd like to thank Avant, who funded my last year of research for my PhD, my supervisors, and some people who contributed some of the data. Any questions?
Results in increased mortality. Were the oliguric patients just getting more fluid? And is that why there was a higher mortality?
So it's interesting. So fluid administration has never been factored into any illness severity model that we have, and we did actually factor it. We looked at it in a bigger analysis, but I think once you start doing that, it looks a bit like data dredging. It wasn't significant. So none of the 12-hourly or 24-hourly or 48-hourly values were significant. They didn't add to the model. And we carried on with C-statistic work as well. But it's really hard to add to ANZROD. ANZROD's a brilliant predictor of mortality. In the cohort that we had, the area under the receiver operating curve for ANZROD's 0.916. And so to improve that at all is incredibly difficult. We managed to do it, but it's by adding in things that look a bit disingenuous. And so I think it's better to present the data as is, and then from that do prospective work to validate it, or validate it in another patient population.
Cheers, Neil. I've got two questions. The first one, it looks like you've taken an absolute value of 30 mils to define oliguria and then adjusted for weight. Why did you pick that way to do it rather than use a mils per kilo? Go on, that.
So we only had 1,000 patients with weight, was the first point. The second point is it's an artificial construct using weight-based measurements of oliguria. There's no evidence for it initially. When it came into the literature, it came from paediatric literature. Everything else is based on the water privation studies from the 1930s and 40s, which there's no weights recorded in these patients. Instead, it was just maximal concentrating ability of the kidney. And actually, when you look back at those studies, it's a range of 20 to 35 mils per hour that people class oliguria as. So we've subsequently taken 0.5, 0.3, 0.1, and they've been validated as useful criteria in things like the FINACI, in the FINACI databases more recently. But it was mainly about having large populations and then recognising that we very rarely have large databases with accurate weights. So it was to see whether an absolute value could be applied to be clinically useful in database work. And actually, the relationships appear stronger than they do for weight-based values. But I think that's maybe a function of there being a different subgroup of patients. Your weight-based patients are all post-operative, and they're a different class of patients than the emergency patients that we get in that form the ones that you might have to make absolute value judgments on.
Okay. And ANZROD already has built into it a prognostic component that is due to the urine output in the first 24 hours. Could that have had any influence on your results?
It would probably have gone the other way. It wouldn't have magnified a result, it would have made it disappear.
Hi, thanks very much for your talk. I'm a resident from Perth. So when you're saying that you looked at diuretics and vasopressors for their association with the urine output, do you think, in terms of the patients with low urine output, do you think it would be better to try and treat them with diuretics to get the urine output up, or are you going to go looking for an underlying cause?
So I didn't look at that, but we would like to look at that in a larger scale. But I didn't have, our database was what it was, and unfortunately we didn't have pharmacology, we didn't have drug administration to factor in. It would have been wonderful if we did, but we didn't. I think you always look for an underlying cause because it's pretty embarrassing dialysing somebody for obstructive uropathy, but some of us have done that. But you always look for an underlying cause, and the honest answer is that we still actually don't know what the right thing to do is.